Yes, ma'am, you were saying something?
No, no, I was saying some maybe because of light, the colors are different actually, looking different. Hmm.
No, it looks fine, ma'am, from your
Ah,
side.
nice. Yes, yes. It's 10 minutes more, na?
Yes, ma'am.
Oh, I joined early actually. Mhm.
Yeah, we'll start at sharp 8:30.
Hmm.
Yeah, hi, Namrata.
Hi, ma'am. How are you?
Fine, fine, my dear. How are you?
I'm fine, ma'am.
I stuck in clinic. Hi, Rajshree.
Ma'am, you're on mute.
या
Rajshree.
राजश्री कैसी हो?
अच्छी हूँ। तो वही अब सोच रही हूँ कुछ ऐसा इलेक्शन विलेक्शन का देखते हैं। सबको बता देना यार।
यस यस यस। हाँ हाँ हाँ।
हाँ।
तरनी मैडम बोल रहे थे तुमने फोन किया था कल। मैडम का फोन आया था मेरे पास।
अभी अभी तुम्हारी मैडम है तो मैंने फोन किया। मैं बोली बाबा आई विल हेल्प यू। आप मुझे
हाँ,
वहां पे बता, आप हेल्प करो। हम
बोले
दोनों तो जुड़े हैं।
बोले मुझे कि फोन आया था। हाँ।
हाँ। मैंने मुझे लगता है लिस्ट भी भेज दी उनको, ऐसा कुछ तो मुंबई वाली ऐसा।
अच्छा, वो सब उतना नहीं बताया, उतना बताया कि फोन आया।
शायद एक्चुअली शी वाज आउट। लेट मी चेक, अगर नहीं है तो इफ शी वांट्स आई विल सेंड इट।
हाँ।
और कैसे चल रहा है?
चल रहा है ठीक। बारिश हो रही बहुत जोर से।
अरे इधर भी हो रही थी, इसलिए मैंने वो एक कोना पकड़ के जहाँ पे नेट आता है मैं बैठी हूँ।
ठीक है, 1-2 मिनट में होती होगी, है ना टाइम?
यस।
हाँ।
हाँ। एक ये लेते हैं ना, इसका बहुत दिन हो गए ना।
क्या राजश्री? क्या कह
बहुत
रहे?
दिन हो गए साथ में ये नहीं लिया ना।
हाँ 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 हाँ।
मैं बोले लेके रखते हैं ना वो।
अच्छा।
हम बहुत दिन हो गए ना करके टुगेदर।
करेक्ट।
मैं वही सोच रही थी इसको। ये बोली ये चश्मा डालो, मैंने बोला था ये डालो क्या। कौन सा ठीक लग रहा है, पहले वाला क्या?
कुछ भी डाल यार, तेरी
अरे
ब्रेन
नहीं,
इतना अच्छा है।
मेरा
लोग
वो
बोलते
नियर
हैं
नियर विजन का है। तो मैंने ये बनाया था
हाँ,
पीपीटी के लिए। वो बहुत ये होता है ना, अपना वो ग्लेयर बहुत आता है।
ये अच्छा है।
हाँ, सब जन बोल रहे हैं यही अच्छा है। डोंट
I said the same thing.
सेम थिंग। तो वैसे आज पीपीटी नहीं है तो बगैर चश्मे का भी बोल सकते हैं।
सही।
2 मिनट्स लेफ्ट।
हाँ, मुझे तो बहुत भूख लगी है। मैं वो वाटरमेलन खा रही हूँ। वाटरमेलन मैंने उसको बोला
पता है क्या,
जाओ, जाओ नीचे से वाटरमेलन लेके आओ, मुझे कुछ खाने के लिए देकर जाओ।
पता है मैं इतनी भूख लगी थी कि मैं खाना खा के बैठी हूँ। बहुत भूख लगी थी मुझे भी।
नम्रता क्या सोच रही हो?
कुछ नहीं, ma'am.
शिवानी को भी फोन किया था रितु मैंने।
हाँ, बताया शिवानी ने।
हाँ, मैंने बोला भाई देख ले, मुंबई के 300 लोग हैं, 300 इसके, दिल्ली के 300 400 हैं।
क्या?
उनके लोगों को तो दे दो, लेकिन मुझे भी एक दिया तो
हाँ,
अच्छा हो जाए, तो
बोली,
चांसेस बढ़ेंगे।
जो बोली फोन आया था। क्या?
हाँ।
हाँ हाँ। तो बोली हाँ हाँ ऑफ कोर्स तो।
करना है ना तो हम लोग थोड़ा
हाँ
आईसीयूजी में जाएंगे मेरे पीछे पीछे। और एकेडमिक विंग है ना, इसलिए वो हो गया। और वो तरीनी मैडम भी है।
हाँ।
देखते सोचा तो अच्छा है।
Ma'am, let's start.
यस, लेफ्ट। Ma'am, join.
Yes. Yes.
Yes, please start. I was just checking in the YouTube. Yeah, it's coming. Yeah.
Yes, we are live now, ma'am.
Yeah.
Good evening,
Yes.
everyone. I'm Namrita Madesh from Medisage E-Learning Private Limited, a leading platform dedicated to empowering medical professionals through knowledge sharing, expert insights, and digital innovation. And today, I welcome you all to yet an insightful med talk on diabetes in pregnancy. We are honored to have with us two distinguished speakers, Dr. Ritu Santwani and Dr. Rajshree Katke. Dr. Ritu Santwani, a highly respected obstetrician and gynecologist, infertility specialist, and sexologist. Dr. Santwani holds qualifications including MBBS, MD, FECOG, FIAOG, and ART Singapore. She is the founder and CEO of 360 Degree Healthcare Studio in UHS Singapore and is recognized among the top 50 influential doctors on social media. Dr. Santwani also serves as the co founder of MAAM and is a board member of SWWC, bringing a wealth of expertise in women's health. Joining her today with us is Dr. Rajshree Katke, a highly respected professor and head of unit of OBGYN, Grant Government Medical College, and former superintendent of Kama and Alblis Hospital, Mumbai. A renowned obstetrician, gynecologist, surgeon, and academician. She has mentored medical students for over 2 decades and authored over 100 national and international publications with 383 plus citations and over 2 lakh global reads. Dr. Katke has served on multiple national health committees and has been widely recognized, including the UN Secretary General Ban Ki-moon and recipients of prestigious awards such as
Bus,
Nobel
bus, bus.
Peace Award
Bus,
and
bus.
Rajiv Gandhi Excellence Award.
Bus.
Experts, we welcome you to the session, and I now request
Thank you.
Dr. Ritu to take the session forward. Over to you, ma'am.
Thank you, my dear Namrita. So, and thank you, Medisage, for providing the platform. I know the Diksha must be seeing from anywhere. So, hello to Diksha also.
Diksha.
So, yeah, a very, very warm welcome to my dear friend, Professor Rajshree Katke. So,
Thank you, Ritu.
me and Rajshree already has done a bundle of webinars. I can,
Bundle.
yeah, on the different platforms, and really thankful to Dr. Rajshree that she never says no to me. At least I can call
Oh,
her anytime, at any time, she never says no to me. I still remember at the time of the lockdown period when we are doing 5, 5, 6, 6 webinars one day. I still remember one webinar me and Rajshree had done at 11 p.m. and that was also a
yes.
very huge hit. We got around
Yes.
500 audience at that time. So
Yes.
now into the topic, friends, as we all are aware, today we are going to discuss something related to about the diabetes in pregnancy. As we know, we all are having lot of confusion in our mind. We all know, yes, diabetes in pregnancy, gestational diabetes, but once the term comes, the diabetes, especially once we are doing our post graduation, that time it comes like a what to do, ma'am, this patient is having a sugar, this is having increased sugar level, now how we can manage. So now coming to you, Dr. Rajshree, as you are in the government setup and you must be managing thousands of patients of gestational diabetes mellitus. So I want that you should start that first for the PG students also, those who join for this, that how we are classifying this gestational diabetes or when we can use this term, the gestational diabetes.
Yeah, gestational diabetes means it is a pregnancy. During pregnancy, if we found the diabetes, that is called as a gestational diabetes. And she is before pregnancy, there is no diabetes. And after the pregnancy, if she delivers also, the blood sugar comes to the normal. So it is a gestational diabetes. And now there are one thing is that in classification that there is a over diabetes. You know, some women, they are a diabetic, they become a pregnancy, and after that we have to treat them a diabetes during pregnancy. That is one. Or some of the cases of the gestational diabetes, in future they become a diabetic. That's around 6 to 7% of that, which they become a diabetes afterwards also. So this is how one should approach to that.
Correct.
Yeah.
So now
And
coming,
there are two types also. We can say that a type 1 and the type 2 diabetes. Type 1 is the one where it is a insulin dependent, and it may be before the pregnancy or juvenile diabetes continue with the adult age in that. And type 2 is the non-insulin dependent diabetes. And then there are the various other classifications, Priscilla White classifications, and many classifications are there. So, but focusing on the diabetes in pregnancy, are these are the two one should look for.
yeah. So thank you very much. So now coming to the next question, as once we are seeing the patients in our OPD also. So a lot of the patients have a query that, madam, one of my aunt or one of my bhabi who has suffered from this gestational diabetes mellitus. So, and later on that was cured. So as we all know that obesity, thyroid, and PCOS all are some are the predisposing factors for the gestational diabetes. Sorry,
Yes.
and PCOS especially. So now coming to you, so I want that you please clarify something more on this, that which patients are more prone for the gestational diabetes.
See, it is very important. It's a very nice question, Ritu. Obesity is the one where the BMI is more than 25. That is the most important thing, is that if she has a family history of diabetes to the mother or the maternal aunt or the even with the paternal side of that, if she has a recurrent pregnancy losses, if she has a more than 4 kg or the large baby weight, if she has a congenital malformation babies like caudal regression syndrome or holoprosencephaly and anencephaly or spina bifida, open neural tube defect or the cardiac anomalies, then one should suspect for this thing. Then the most important thing, as you have said, that there is a tendency of the PCOS become a pregnant, and if she has, she is having a insulin resistance, that is the one very important factor in that, and that can lead to again the diabetes. So these are the very high risk cases where we should screen. Ideally, for all the patients, you are supposed to screen for the diabetes, because we are going towards the capital of the diabetes. Now only we have a capital of diabetes, but we will have a large number of the patients in 2030. So basically, all these things one should keep in the mind, that we should screen for the gestation diabetes.
Yeah, very true. So yeah, thank you for clarifying all this. Now, as we know that, do you think as we know that we recommend the patients for HbA1c testing also. So do you think that how it plays very important role, or it plays or not plays a role of HbA1c in during the pregnancy?
See, one important thing is that whenever as a routine we are doing, there are the one normal cases and one is the high risk cases. In some normal cases also, if you do a random blood sugar and if it is very high in that, then she's definitely the person which should be screened for that. Then the second is that where the gestational diabetes, the high risk cases, there we can do for the OGDT or the DIPSI test in that. But the basic thing is that to know the euglycemic control even before pregnancy, the glycosylated hemoglobin is very important in that. See, what happens in that, we should understand the diabetes not only have a problems afterwards during the pregnancy, but it will have the problems to the fetus, because they are having lots of congenital malformations we can see in cases of the diabetic mothers in that. So what it happens in that, if suppose she is a diabetic, then within the 5 to 8 weeks of the period, there will be the organogenesis. In that period, she should be euglycemic, or there has to be a normal blood sugars. That's why if suppose if they are coming for the preconceptional counseling and they become pregnant, the hemoglobin A1C or the glycosylated hemoglobin should be less than 6.5. That is the ideal thing in that. And then if suppose it is not being there, if they are coming preconceptionally, then definitely we are supposed to treat them, bring the glycosylated hemoglobin down or the sugar down, and then she can conceive, so that there is a less or nil chances of having the congenital malformation for the baby. So it is very important to look in this also, because sometimes what it happens in the recurrent pregnancy losses, first abortion, second abortion, in on third it comes to that it has been a raised sugar and all. Means so screening is very important for the diabetes.
Yeah. So now, you think that in the patients of this who are at the risk for the gestational diabetes mellitus, you think while we are seeing means that these kind of patients of PCOS, obesity patients in our OPD, so related to as they are in the high risk chances of the GDM, so you think that there's some counseling is very important while checking these patients? If yes, so some points you if you can share, that will be good.
No, no, it is very important. Even I'm saying for the normal patients, if they are coming even in a gynecopedy also and they are obese nowadays, I just counsel them about whether they will be prone for the diabetes or the hypertension. There will be a cardiac risk and all those things. But during pregnancy, if you feel that the BMI is around more than 27, more than 30, sometimes the patients they are coming with highly obese and more than 35 in that. So in that, counseling is very important for them, for the screening purposes, for the diet modifications, for the exercise, telling them about the complications of the fetus and complications during pregnancy. And it is very important to tell them, because what it happens if suppose suddenly during labor, if she has a complications, that time she will say, oh, my doctor has not told about that, I was not prepared for that. So even a medical legally also, it is very important to give some time to talk to the patients, especially when they are the high risk group of that. So that is very important. I feel so.
Correct.
And I do give a time for all, most of the patients. Personally, I do talk and I explain to them so that they should be aware what's happening with their body, what will happen if suppose they don't get, and you need a better, for a better control, you need the very good confidence in the patients. That is very important, If suppose you develop a rapport with them, you can tell her that no, for the exercise you go, for the nutrition, because these are the two prongs to control the diabetes apart from the medicine also.
Very true. Very. Thank you for clarifying this. Now, coming to this very important term, the medical nutritional therapy, MNT. So, for
Yes.
the role of this diabetes, managing for this gestational diabetes mellitus. So, please share some points.
See, one is the, if there is not a over diabetes and there is a hyperglycemia, that is the one thing, and the obesity is there. And in that, if suppose she is prone to get or the high risk for the diabetes in that. So what we can say that you should go for the, nutritional therapy, medical nutritional therapy. And you can give a trial for the 2 weeks or 3 weeks for that and again check for this. For example, if suppose normally, a pregnancy is classified as classically, there is a fasting hypoglycemia and some of the postprandial hyperglycemia. So in that, and even the glycosylated hemoglobin, because of the RBC, RBC, this thing, the changes in the RBC volume, the glycosylated hemoglobin also it comes down. So it is not in pregnancy also you have to take this as a with caution, the level of the glycosylated hemoglobin. So what it happens in that during pregnancy means you are supposed to do all the screening test also, and the test to include all these things, and you can start with the medically this we can say nutritional therapy and see for the response. And if it is not getting resolved, then we can go to the proper treatment of that. But not only the nutrition, but basically nutrition with exercise, these are the two important things. While talking about the nutrition, what is the part of the nutrition is that the mainly the sugar is increases with the carbohydrate. As Asians or the Indians, we are having lots of carbohydrates in our diet. So basically, what we want is that the protein should come up. Protein should be more than that, 1 gram per kg, you can say that. And if you take a thali of this thing, so it will have a 1/4 portion of the carbohydrate. Then that 1/4 of that this thing, with the salad or the fruits and all. And most of the part, it should be around 40 to 50% of the proteins with this. The proteins comes with the either the animal or the proteins, or she can have eggs or the meat or the fish or the you can say that dairy products like milk and all. So these are the things. The protein, one should go ahead with that. And there are the two types of the sugars, you can say. If the in the cereals also, pulses, you should go get it more than, because what it happens if you take with the lots of gehun ka chapati and all these things, those sudden there will be a rise into the all these spike of the sugars. Even in the fructose in the some of the fruits, it gives the sharp rise of the sugar of that. So the sharp rise of the sugar, again it sensitizes the insulin in that, and the insulin will have a more spike of that. So we are working on with the diet we are reducing the carbohydrates, so amount of the sugar we are consuming it will be less one. But at the same time, the insulin resistance at the tissue level, it has to be reduced down. What happens during pregnancy is that pregnancy is the diabetogenic condition, like there's a pregnant all placental hormones, HPL and all those things, it will increase the insulin resistance. And if there is a insulin resistance, then that will affect the carbohydrate metabolism. And second thing is that there is a beta cell dysfunction in some cases. In that also there will be a reduction of the insulin production and insulin resistance. So ultimately whatever the carbohydrates we are getting it, it is not being neutralized by the insulin. So this gives the condition of the hyperinsulinemia or the diabetes, and it affects to the fetus in that. In the fetus, it will be again, it will increase the blood sugar level, increase the insulin level. There will be a fat deposition, the metabolism of the fetus. I mean, every system it will get affected. Baby will be a macrosomia. There will be a polycythemia, or these babies they will have a hyperglycemic condition. They are prone to go into the neonatal hypoglycemia after delivery much more.
Yeah, very true. We have to keep all these points in our mind. So now
Yes.
coming to the another very important query that is related to this diabetic ketoacidosis during pregnancy.
Yes. So,
So, uh,
so diabetic ketoacidosis. Yes, yes, please.
so how to manage that diabetic ketoacidosis?
See, diabetic ketoacidosis, one important thing is that you are supposed to diagnose it very properly. See, suppose one patient with the diabetes, if they get unconscious or altered sensorium, so first thing in our mind comes to, array, the sugar might have been down also. But sometimes it could be the otherwise also. So basically, one should look for the two things. One is the blood sugar spot in that, and if you suspecting it, see for the serum ketones or the urine ketones. That is very important, because in the diabetic ketoacidosis, if we give again the glucose, it will get worsen the condition. In hypoglycemia, if you give the glucose, that will treat the conditions in that. So this is the dial emergency. You are supposed to admit it. Especially one should go with the intensive therapies for that, and very good monitoring of the blood sugar with the insulin drip is very important in that. And during pregnancy, what it happens is that you have to monitor considering with the fetus. So what are the blood sugars levels in that with the supportive treatment, one should go for the insulin you can give with the form of the insulin pump, or you can give the combination of the rapid plus the intermediate also, or the long acting insulins. And that you can do according to the sliding scale of that. We can start with the 0.2 units per kg or 0.3 units, depending upon that. We can't say that we should start this much and this much and that, and then we have to control in that. So once the sugar gets under control, then the ketone levels, the ketone basically it is the byproduct of the metabolism, and then it ketones they get washed it out, and then it comes to the managing the things. And at the same time, you have to just see the monitor the fetus very carefully. This is the one thing with a very good monitoring of all the sugars, everything in a good setup also, there are chances of having the unexplained IUFD or the unexplained decelerations, because we don't know how the fetus inside is having fluctuating the blood sugars also in sometimes. Because we have seen the patients, means there are many patients which I kept for 9 months admitted, and patient used to, after taking the insulin, sustain sustainably around 200, 250, 240 and requiring 32 units of the insulin. And then also the baby, we have delivered the baby and we have given the nice baby. But at the same time, there are some patients where we have done lots of monitoring everything and all, but in a very good centers also, sometimes you will have the unexplained IUFDs or the intrauterine growth restrictions. These are the problems. Even with the macrosomia, delivering of the babies is one of the very challenging thing, where you will have injuries, obstructions, or dystocias. Even with the during cesarean section also, it is very sometimes difficult to deliver, or there will be chances of PPH extension. So these are the things one should look for the complications of this.
Yeah, very right. Heard all the things. As we all know, yes, the unexplained IUFD is a most common threat in the patients while we are managing of the patients of gestational diabetes. So, dear friends, if you are having any doubt, because as the program is very well seen by some postgraduates also, so please don't wait. If you are having any fetal deceleration, please don't wait by giving any. If the patient is approaching term, please don't wait. Try to take out the baby as early as possible. 2 days back only, Rajshree, one doctor has called me from the periphery that the patient is having a gestational diabetes, and the patient came to him with a decreased fetal movements. 35 weeks, 35 weeks, 4 days, round 30. So once patient approached them, they have seen that time the fetal heart rate was borderline. It was 120 to 140 in के बीच में. But in the end, there are some deaccelerations. So I told them कि नहीं बाबा, you give the steroid cover and take out the baby as early as
Yes, 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 yes. Very true. Very true.
Then they called me कि no, the patient is not ready. Patient herself is a biotechnician. She's saying no, no.
IUFD हो गया उन्हें.
कि 30 weeks का पूरा होने तो we will wait for 3 days. So he kept in the hospital only in the patient. 9 p.m. he called me, and by morning again he called me that it was sudden IUFD. So
yeah, that is.
Yeah. So that's why I've shared this case here, because this is very important in the patients of the gestational diabetes. Sudden IUFD is very, very common. So please be very, very.
Yeah, we have one doctor only, and she was there, I mean, in a best of the center, and it was a sudden IFD also. So once they show the signs of deceleration or sluggish movements are there, so it is always there to take it out the baby and nurture the baby outside or the. So these are very important things in this.
Very true.
Very true. So in that, diabetes is always like, then the one is the brittle diabetes, where the brittle diabetes is the one type where you can say a long fluctuating of the sugars. Sometimes you feel that it has normal, sometimes it goes up. So that fluctuation is very, very dangerous for the mother also and to the fetus also. That is called as a brittle. And one important thing, I mean, I would like to add is that with the diabetes, so you can start with the low dose aspirin also with this, because these patients, they are prone to have a preeclampsia. That is one thing. And there is a microangiopathies also in diabetes. So diabetes not only involve only with the pregnancy, in that it will cause the preeclampsia, pregnancy induced hypertension, or any abruptions and such other things also. And also it can affect the kidneys, retinopathies, nephropathies. So these are even the cardiac complications if the diabetes is not being controlled. So we have to investigate in that way also, if suppose they are having a irregular control of the diabetes is there. So continuous glucose monitoring, then involvement of the insulin, titration of the insulin with the blood sugar, and surveillance of the fetus, and prevention of or keep a watch on the complication. This is the key note for the success of the diabetes during pregnancy. So it is very important to have all these things, and it is not only gynecologist work. You can have a good nutritionist, then diabetologist, the physician, and the pediatrician, and the obstetrician. So it is basically it is a teamwork, multi-speciality work is there. Sometimes you require for this.
Yes, this is very important. So as Dr. Rajshree has very rightly pointed out, so please never hesitate to take help of your different specialties also. If any doubt, yes, don't hesitate. If you are having any problem,
Yes, yes, very true.
yeah, so please take the help. There is nothing like that. So now we have received one question related to the role of metformin in gestational
Yes, yes, I was about to come for this. See, in a diabetes, the oral hypoglycemic agents, they are contraindicated, like a sulfonylurea, because they go and cross to the placenta. Some are the teratogenic, and some of the glyburide and all. This is that it causes the neonatal hypoglycemia. Or so this is the thing. But metformin is the one ki now we recommend for during pregnancy also. So one can use for that around in the capacity of start with the 500 milligram and this. But ideally, what I feel for the first trimester, when the period of organogenesis is there, one should go for the insulin, and after that, we should start for the metformin. And sometimes there is one question is that ki people with the infertility treatment, she gets conceived, they have started with the metformin, and after that they says what to do about it, then they can continue with that. You can explain the risk. But basically 5 to 8 weeks or the first 12 weeks are there, you should be very cautious to control the sugar, and at the same times at the same time you should not have a OHS which cause the congenital malformation for that. So we have to explain to her, and you can continue from the after 12 weeks, and then you can start with this. You can go up to 2500 milligram per day also. That dose is there.
Yeah.
And another one is no, they don't have so much of the promising results for that. We can start with the 2.5 milligram glyburide, and it can goes to with the 20 milligram of that. But what they say is when it crosses to the placenta, then that causes the neonatal hyperglycemia is more. Sometimes hypoglycemia is more in that. So what they are saying with the metformin, the results of macrosomia and the neonatal complications are the same like a insulin. So it is that way people have started it, and it is doing well in pregnancy also with that.
Yeah, very pointed out. So especially, yes, with the metformin, the price is less and there is no more tension of taking the injection. Yes, but as Dr. Rajshree has also pointed out, yeah, dose we decide from 500 to, because in my practice, are given more than 1500. So
Yes, yes.
of course, the literature has mentioned up to the 2500. So yes, but whenever, yeah. So, but whenever you are giving this metformin, yes, of course, the proper monitoring, proper vitals taking is also very important. So, yeah, thank you
And
very much, Dr.
vitamin B12 also, you have to give the additional supplementation of folic acid and vitamin B12.
Yeah.
That is also very.
Yeah. Vitamin B12 is must because the metformin causes the B12 deficiency. And especially I have seen if the patient itself that you are having a gestational diabetes mellitus, हम मीठा खाने को, कार्ब्स खाने को मना करते हैं, तो उसकी जगह हरी सब्जियां बंद कर देते हैं, या एसिड्स के सोर्स बंद कर देते हैं. मैम हमें घर पे किसी ने बोला था डोंट हैव टू टेक दिस, यू डोंट हैव टू टेक दिस. So another question related to this gestational diabetes patients, what do you advise best for the postpartum contraception?
Postpartum contraception is that basically if they have a completed family, then they should go for the either permanent method like female or male sterilization like that. And if suppose they want, then after 6 weeks, then they can use the barrier. That is one thing. And unless it is being healed and all, the IUCDs, they may cause the endometritis and all those things. But low dose hormones depends upon the BMI that they can try for that. But basically in lactation, we look for the only progesterone, only pills, POP pills.
Yeah.
But that also, it depends upon the gluconeogenesis, and it alters the steroids and the hormones. It has to be very judiciously used in cases of all these gestational diabetes, because it should not increase the metabolism of the carbohydrate with the neuroglucogenesis.
Correct. Very rightly out. So thank you for that. Yeah, Namrata, you can take last one or two questions as we are coming to the closure, because gestational diabetes is a very big
Very, but
topic.
still, it is a way I enjoyed
Huh.
Yes.
You
So, ma'am, the question is, how do you manage diabetes in twin or multiple pregnancy? Targets or treatment protocols are different?
No, basically it depends upon the sugars. I mean, the insulin resistance with the big placenta and all, if it is more than, we are just taking it out the how much is the glycosylated hemoglobin, how much is the sugar is there, and then we have to manage the sugar level. The only one thing is that about the weight gain. The weight gain is you have to monitor depending upon whether she is obese or moderately built or thin built is there, and accordingly we have to treat for them.
Like in first pregnancy, if the woman is like prone to gestational diabetes, so in the second pregnancy, will it be continued or like she will be having it or not?
No,
It's
basically, see, you can't say like that. First, in pregnancy, if she has a gestational diabetes, after that she comes normal. In second pregnancy, we have seen patients where in the second pregnancy, either she may have she will have she may have a gestational diabetes also. Yeah, sometimes with the gestational diabetes, after delivery it comes normal, and again she may become a diabetic also, and she become a she become a diabetes during pregnancy.
okay. So, ma'am, the next question is if a patient is diagnosed later after 32 weeks, how aggressively should we manage sugar?
You have to, because around 30, around if we can do a, we do a screening around 24 to 28, around 28 to 32 weeks, the insulin resistance is more in that. And at this time only, you will have the weight gain is also there with the pregnancy weight gain, and the baby's growing chart is also in that. So you have to manage it properly with the both fetal monitoring and the this thing. You can start either with the metformin or depending upon the blood sugars, or you can start with the insulin depending upon you can give the combination of the either with the long acting with the plain insulin or the intermediate acting with the plain insulins, depending upon the sugar and the sliding scale of that. We can go with around point you can say around 32, so 0.6 units per kg you can go in that. What they say is around 37, you can go with 1 unit per kg, but depending upon her blood sugar, what is the status of that.
Yes.
And but at the same time, you have to monitor about the fetal growth is there, serial monitoring of the ultrasound, Doppler studies we have to do on that, and whether the fetus is growing properly or not, we have to look.
Okay. And when to decide like to admit that diabetic pregnant woman?
Ideally, for the diabetic pregnant woman, it has to be under observation. If you are having a good setup and all, it's not possible for a normal diabetic to keep. For some people, in the thing is that, but you have to admit it, monitor the sugar, and you can keep a watch on that. If suppose she has a irregular blood sugar or the fluctuating blood sugars are there, then you admit it, and if she requires, then you can bring this patient to from the high diabetic to the euglycemic, and you can continue with the same treatment for that. But
Yes.
don't get scared of admission, or if you require also, this is not I'm talking about the bookish picture of that, but my experience of 30 years in the obstetric, high risk obstetric also, I'm telling you, in some of the cases we have kept the cases to admit it till 7 months, 8 months and all. One of the patients, she has lost around 4 5 pregnancy losses, and she was very keen on that, and she got pregnant, and what she got educated patient. So I kept her admitted in my ward for 8 9 months, and then we delivered with the strict observations for that, because she lost for 4. But at the end of the day, it depends upon the individualization is very important. But don't feel that key, let her go home, let her monitor on her own. That is not the question in cases of severe pregnancy-induced hypertension and in diabetes.
very
Monitoring is very important. This is my and Ritu's around 30 years of experiences, words of wisdom. Yeah, words of gray hairs. Right?
right, right. Thank you so much. So I think we will take one more session on the gestational diabetes because it is a very vast topic. Still,
Yes.
queries are unanswered. So
Hmm.
thank you once again, Dr. Rajshree,
Array.
for sparing your valuable time with us.
And it's a pleasure to be with you. I was just waiting only when we will click the
Yeah,
things.
and
So whenever you call me, I will be always there. We can
thank you
share.
so much.
Thank
And thank you, very beautiful Namrata. Thank you so much for always being such a calm and smiling girl.
you. Very nice, very nice.
So with this, we will wind up for the session for the today. So thank you, dear
So
friends,
thank you.
all who have joined. So yeah, over to you, Namrata. You can give the concluding
Thank
remarks.
you.
And
Yes, ma'am. Thank you, Dr. Rajshree and Dr. Ritu Santwani, for an insightful and clinically relevant session on diabetes and pregnancy. And we deeply appreciate the time and expertise you've shared with MediSage community today. And to our viewers, thank you for joining us. We hope this Med Talk has enriched your understanding and sparked important conversations around patient education. So don't forget to explore more such expert-led session on MediSage app. So till next time, stay tuned, stay informed, and stay empowered. Thank you. Good night.
Thank you. Thank you so much. Bye bye.